It's a real pleasure to be here today. This is a research day, and so Andrea asked if I would come and talk about CBME, but I don't really want to just talk about give you my usual talk on what is CBME and where are we going in Canada. I wanted to try to give something that looked a little bit more like a research influence talk so that you can see a bit about some of the ways in which research in education interacts with what is the future of medical education in Canada. So I also have to put a disclosure slide in there, and I was inclined to say I have nothing to disclose, but I should say that CBME is actually being driven by the two certifying colleges in Canada, the College of Family Physicians, which actually converted to a competency-based curriculum in about 5 years ago, and the Royal College. And I'm a co-investigator on a bunch of Royal College medical education research grants, so I don't think that's a particular conflict, but I disclose it to you anyway. I've spent much of the last 10 years of my research career studying feedback, how feedback gets exchanged in learning settings, both in medicine and outside of medicine. I've also, as a program director for a number of years, and then as postgrad dean, I've had a lot of firsthand experience, as have, I'm sure, almost all of you, with the challenge of trying to give feedback, especially when it's difficult or when it's critical or when it has to be corrective. So I think I have an understanding both from a research perspective of why feedback is sometimes a challenge, and also just from a personal perspective of trying to address it. So what I'm going to talk about today is some of the issues around what makes feedback meaningful for learners and what makes it sometimes fail to become meaningful. And I'm going to try to link that a little bit to what's happening in terms of the competency-based medical education movement in Canada. So I'm going to start with this motherhood statement. Learners need feedback. You can say this in front of audiences of educators and teachers and clinicians really anywhere in the world, and it's really hard to find anybody who disagrees with that. We tend to deal with feedback educationally as if it's breathing, and we kind of accept it as a given that, of course, it's an essential element of learning. So for a researcher, that's actually a wonderful thing to study. Anything that's kind of a taken for granted assumption is really interesting to study because for me, I want to get under why do we place so much faith in feedback? Why do we put feedback at the center of clinical education? What do we expect that it's going to do for us? What do we expect it's going to do for learners? And how is it that feedback actually becomes meaningful? More to the point, how is it that sometimes feedback actually fails to be influential to learners? And we all know that can happen too. Well, the promise of feedback, what it's supposed to do, is it's intended to provide some direction and motivation for learning. Feedback done well is supposed to actually tell people how to get from point A to point B. Definitions of feedback that I like include that element of action. It's not just giving people information about their performance, it's giving them information they can use to actually move the way that they're doing things forward, to enhance their skills. So that's the promise of feedback. And in 1983, Jack Endy wrote this really influential article that holds up wonderfully today about feedback in clinical education, and he talked about the consequences of a learning environment that doesn't have effective feedback available. He said that without effective feedback, mistakes go uncorrected, good performance is not reinforced. That's important because we tend to think of feedback sometimes as just corrective, but a lot of it's about reinforcing what's done well. And he went on to say that without feedback, clinical competence is achieved empirically or not at all. I want to just backtrack a little bit to put this in the context of residency training, which is the area of education that I know best. And to give you a little bit of background, this is the CBME portion of the talk today. I'm going to give you a little bit of background about where we have come from, where residency training is, and where we anticipate it's going to be in 5 or 10 years. Where we are is something that looks like this. So traditional postgraduate medical education in Canada has been described as a T-steeping model of education. That really means that we measure education, we organize our education around time. Just like you put a tea bag into hot water, you leave it there for a set period of time, and then very reliably you can take the tea bag out and you have a good cup of tea. And the idea with residents is that you put them into an environment where they can learn to be a radiologist, a nuclear medicine specialist, an obstetrician. You leave them there for a fixed period of time. You expose them to certain experiences that last fixed periods of time. And at the end of it, they are competent practitioners. And you know, a good deal of the time that works. Canada has historically had and still has one of the best postgraduate training systems in the world. And we should all be proud of the residency training that we've been able to offer for the last 50 years or more. And a lot of it's been organized around this, so it's served us reasonably well. The problem, though, is that time as an organizing principle for education is a bit challenging. Time is not a perfect marker of competence. Time is not even a perfect marker of experience. You know, a resident could spend a month doing a particular rotation, and then another resident spends a month doing that same rotation, and they will have different experiences. They'll see different types of cases. Maybe one of them will get to see a couple of rare cases or do a procedure or two that don't come up all that often, and the other resident won't get that experience at all. So we know when we organize things around time that there's a certain kind of randomness and unpredictability that starts to creep in. So competency-based medical education is really just the education system's response to that. It's socially accountable training that says we have to be as sure as we can be when people are finishing a training program that they can be trusted to take on, without supervision, all of the essential tasks of the profession. So to plan a competency-based medical education curriculum, you have to start with that idea of what are the essential tasks of the profession anyway. Start with the outcomes, and then work backward and design a curriculum that helps to get people there. That's all competency-based medical education is. It's outcomes-oriented, so that the outcomes are the organizing principle rather than time. Now in Canada, practically speaking, we're not ready to throw time out the window just yet, in part because residents play a really crucial role in providing healthcare services, and if you remove time from the equation, you remove the predictability of that, which could be really chaotic. But as an educational organizer, time takes a backseat in CBME to outcomes. Processes are secondary to where they actually lead and what the endpoints are. So an individual learner's journey to becoming a competent practitioner may look something like this. And for most of us, this is how it has looked too. Twists and turns, periods of time when you're actually progressing very quickly, and then some times when there are little hiccups in the progression and a little more time is required to really master something. So competency-based medical education, just returning to the idea of feedback, competency-based medical education really raises the stakes for feedback. It means if we're going to actually help people to move as efficiently and effectively along this kind of twisting road to finishing their training and to being competent practitioners, if we're going to help them and guide them in a useful way, we'd better be very thoughtful about how effective our feedback is. A lot of the emphasis in discussions about CBME has fallen on assessment, which is really important. But equally important is the idea of feedback, which is really about development rather than judgment. It's about helping to move people in the right direction. So if the stakes are high for feedback, and if we tend to accept that feedback is just kind of like breathing and learners need it, I think it becomes really relevant to ask this question: does feedback even work? If we're going to invest in trying to create environments where effective, constructive feedback is readily available, we need to know if it's a worthwhile investment. If all of you are going to invest time in training to become even better at having feedback conversations that work, we'd better know that that's a good use of your time. So I want to try to address this, and the answer is kind of a qualified maybe. There's been lots of research on feedback to try to address this very question about whether feedback is even an effective educational intervention. So the best analysis of this, I think, is by Kluger and Denisi in 1996. And they actually looked at 131 studies of what were called feedback interventions, situations where performance was measured linked to how feedback helped it or not. And to be honest, most of these interventions were not specifically educational. They looked at feedback in improving adherence to regulations, feedback in improving motor reaction times, so a kind of an analysis of lots of studies. What they found was that feedback had a beneficial effect overall. So that's kind of reassuring. It works. But the bad news is that they found that the impact of feedback on learning was modest rather than dramatic. And in about a third of the studies that they examined in their meta-analysis, feedback actually made performance worse. So that's a bit concerning. Drowns had actually found the same thing 5 years earlier in a meta-analysis of 50-odd studies of feedback in the setting of test-like events. So basically education-oriented feedback, feedback to improve people's test performance. And he found the same thing. Feedback worked overall, but in something like 18 of 51 studies, feedback actually made test scores go down. When people want to cite a study that makes feedback look a little better, they tend to cite Hattie, who did a synthesis of all kinds of influences on student learning and found that feedback was right near the top as one of the strongest influences of student learning. So that's kind of reassuring, but even he found that the effect size of feedback was hugely variable from one setting to the other. So taken together, all of these things tell us that feedback has potential, that it can work, but that we can't just treat it as a given that it will be effective or meaningful for learners, and that if we are not careful, we can get it wrong, and it can actually be harmful to learners. So my takeaway from this is that feedback is a potentially useful intervention that has to be treated carefully. Probably the first study that I did, I'm a qualitative researcher, so basically that means I listen to people's stories and I try to make sense of them. And one of the first studies I did looking at the things that had influenced people in their learning, one person said this: "I can't even think of any time I got feedback that was useful." I just want to contextualize this for you. This was said by somebody who had done 4 years of medical school, 5 years of residency training, 2 years of post-residency fellowship, and was 2 years into her first job. And this all happened in the 21st century. So we've been talking about the necessity of feedback in medical education for 30 years or more. So how is this even possible? I think the truth is she probably got some feedback along the way, but I think this at least gives you the sense that feedback is often kind of seen as a marginal influence for learners compared to a number of the other things they can pay attention to. And this should make us concerned about the consistency with which we're creating feedback that's really meaningful. So let's talk about why this state of affairs would be. I love this quote from Higgins, and he was not writing about medical education, he was writing about higher education. But he said that the process of feedback as communication is inherently problematic. Another way of putting that is that feedback is just a weird way for human beings to communicate with one another. It's difficult. These are not normal, comfortable conversations to have, and that's part of the problem. But the conversation idea, I think, helps us here. One of the most useful things for me in thinking about feedback is to move away from thinking of it as a commodity, as something that we create and package up and give to someone. Here's your feedback, I hope you like it. And move toward thinking of feedback as a conversation. And if we think of feedback as a conversation rather than as a commodity, then it really helps us to start paying attention to a number of things that we wouldn't think of if we were just thinking of it as a commodity. If it were just a commodity, then it would only be about the words that we use, and the words would be enough. But if we think of it as a conversation, then we can start to consider all of the things that make conversations tick and how those things might impact on that feedback conversation and whether it ends up meaningful or not. So conversations have words, the content matters, it's not unimportant, but it's not everything. The players involved, who are they? Who has power over whom? What's their relationship to one another? That matters. And then the context. A conversation that occurs at an imaging station between a experienced radiologist and a first-year resident is quite different from the kind of feedback that might occur between a hockey coach and an experienced player, right? Or between a child learning karate and a karate teacher. The context really matters. The things you can say, the way you say them, the way that you get resonance in what you say is quite different in different contexts. So let's just examine some of that. Most advice around feedback centers on content. And you can find many, many articles in the education and medical education literature with titles like 12 Tips for Giving Better Feedback in Clinical Education. These are not unhelpful articles, but they all tend to focus on content. And the age-old advice about good content in feedback, which probably most of you have heard many times, it's actually very sound. To be effective, feedback should be timely, it should be well-informed, often by direct observation of what it is you're giving feedback on. It needs to be specific rather than vague, right? It needs to be actionable, and it needs to be task-directed rather than person-directed. So as much as possible, directing feedback at the thing that was observed, the task that the individual is doing, rather than the individual themselves is important. And Kluger and Denisi, who I cited there earlier, went on to develop something called feedback intervention theory. And at the risk of boiling down a life's work into a single line, what the theory actually says is that feedback that is harmful to self-esteem is less likely to be effective. So task-directed feedback is less likely to be harmful to self-esteem than person-directed feedback. This is all really good, sound advice. The problem, I think, is that advice around feedback has often stopped there. But it's helpful advice because it emphasizes two things that I think are most important about the content of feedback. It needs to be constructive, and it needs to be credible. Constructive feedback is feedback that learners can use, and credible feedback is feedback that they trust, feedback they believe. And it has to have both characteristics in order for it really to land and be meaningful. But the words aren't everything. Who's involved in the feedback conversation? How well do they know one another? What is it they're trying to accomplish in that conversation? So for a teacher to be a credible source of feedback, at least in our profession, they tend to have to be good at the job. That probably seems really obvious to all of you, but if you look at other fields, for example, sports, a great coach does not actually have to be good at the sport. They have to be really knowledgeable about the sport, but their job is to make the athlete good at the sport, not to be good at it themselves. Even some top musicians will say that they're significantly better at what they do than their music teacher, but that's not what their music teacher's role is. But in medicine, credibility tends to come with being good at the job. It's just the way that it is in the profession. And credibility also comes with being engaged in the process of constructing useful feedback. So medical students and residents tend to look to people who are not just good at the job, but to people who have really spent the time with them and put the thought in to indicate that there's some engagement in the process of trying to teach them well. And then learners also need to be engaged for the feedback conversation to work. It's not enough for a teacher to say, I'm really engaged in this, I'm going to give great feedback. If the learner is not so interested in having feedback at that moment, is not engaged in the conversation, then it may not work either. And learner engagement depends on things like whether they trust in the fairness and credibility of the process by which the feedback was generated, and also how it aligns with their own self-assessment. It's very hard for any of us to get feedback that conflicts with our assessment of ourselves. If you know that you're struggling with something and that's the feedback you get, you can actually make use of it. If you think you're good at something and you get feedback that you're struggling with it, it's very hard because it creates this sort of discordance. And when we think about the players, the emotions are quite important. There's research to suggest that teachers often, in medicine at least, temper negative feedback for fear of emotionally harming learners. And we also know that learners often have a great deal of difficulty integrating and using feedback that engenders a strong negative emotional response. So emotions often get in the way of even credible and constructive feedback having an effect. So increasingly, we're learning that the relationship between the teacher and the learner can matter. And it matters mainly around this issue of trust. That in trusting relationships, it's easier to exchange difficult feedback. This is why I think sometimes it's easier for sports coaches and music teachers to exchange really harsh, challenging feedback. Because there's an element of trust and safety that's developed in that relationship, which often develops over time and can be difficult in medicine in our kind of rotating approach to learning when people often don't have the time. You maybe do a little bit better in radiology than in some disciplines. I think of poor internal medicine residents who really might work with a different preceptor every week for the whole 3 years of their core training. So where do those trusting relationships develop where sort of difficult feedback can be exchanged a little bit more freely? And there is some evidence, for example, in undergraduate training, something called a longitudinal integrated clerkship, which is where instead of having a clerkship where the medical student rotates every few weeks to a different place with a different preceptor, they situate the medical student with the same preceptor, usually a family doctor, for their entire clerkship. To learn surgery, they follow patients who need surgery from their practice. To learn obstetrics, they follow patients through an obstetrical process. To learn imaging, they actually look at the imaging that their patients have required, but they're situated with a single preceptor. Their performance ends up the same in terms of their exams and their knowledge. But what seems better is the exchange of quality feedback, among other things in that setting. And a lot of that is just relationship and safety. And then the last thing that really matters in a conversation is the context for the conversation. So just think about the range of different places where feedback might be exchanged to train people to do something. Whether you're learning ballet or how to do a surgical procedure or learning how to play the guitar or learning golf, the exchange of feedback is a routine part of all of those things. But in each of those areas, the way that feedback is exchanged, the kind of the norms and the routines is quite different. And learners that are really comfortable receiving feedback in one setting might really struggle to get feedback given in the same kind of way in a different setting. I'll give you an example to illustrate this. A couple of years ago, I did an interesting study where I talked to medical doctors who were also trained to an elite level in a different field of endeavor, mostly musicians and athletes. But I talked to one ballet dancer. She was, before she went to medical school, was an elite ballet dancer. And she said, you know, in the dance world, critique is highly prized. And I tried to imagine any medical student or a resident saying that about our particular culture. So I asked her to elaborate on that a little bit, and she said, well, there are two things. Critique really for dancers is the only way they can imagine getting any better. How are you actually going to get better if somebody doesn't watch you and tell you how to do things differently to make it better? But the second thing she said I thought was much more interesting, which was that critique in dance signaled that the teacher thought that you as a dancer had potential. She said the worst thing that a dancer could hear was, that was lovely. Because that indicated that the teacher either wasn't paying attention or didn't think that they were even worth creating critique around. And I've talked to other dancers since then who are now in medical training, and most of them have shared a very similar story about what it's like to learn to be a ballet dancer, but they've also mostly said that their comfort with critique in the ballet world did not translate to being comfortable with critique in their medical training. And that, I think, is just partly cultural. It is not cultural and normal in the same way to receive regular critique as a way of improving in medicine. That's not necessarily a problem, it's just a feature of our culture, which means that the way a conversation works over here is not the same way that it might work over here. So learning culture matters, and learning culture is really the practices and customs and beliefs and values that underpin how a profession decides to educate its own members. If we think about learning culture, though, it asks us to shift fundamentally what we think learning is and where we think it happens. So I'm a neurologist, and when I started thinking about learning, I thought of it in the only way that I knew how to think about learning, which is that, of course, it occurs up here, right? All of learning must occur in the brains of the individuals who are learning. That's sort of a cognitive or an individualist view of learning. But there's another perspective on learning, which is called the sociocultural perspective on learning, and that says that people learn as they gradually become members of a professional community. And through their social interactions and their presence in that community and their gradual movement into taking on the tasks and the work of the members of that community, they adopt the customs and the beliefs and the attitudes and the skills and the values of that community. So this makes a lot of sense to me, and if you buy it as well, it means that we really need to pay attention to culture if we're going to understand how to make things work in CBME, but also how to make feedback more consistently effective. So what does culture actually have to do with feedback? I have had a chance in my own research to spend time with music students and athletes and teachers in training, and of course, doctors in training. And I haven't found a culture yet that doesn't value credible and constructive feedback. So those things seem to me to be relatively universal. But what constructive looks like in one culture can be very different from what constructive looks like in another culture. For example, if you talk to music students, they don't tend to see something as constructive unless it's what we might call negative, unless it contains some kind of important correction or some kind of important try it this way instead of that way. That's what they view as constructive. They're actually not that interested in praise, apart from the fact that we all like a little praise from time to time, but they don't acknowledge that it really helps them to get better. If you talk to teachers in training, they tend to view constructive as being really framed around positive and reinforcing, probably because they're being trained to teach little kids. But they'll talk, one of them said something like, feedback should be 2 stars and a wish. 2 things you're doing really well, and 1 thing I wish you would be able to get a little better at. So a very different framing, also considered constructive, but just a different way of putting it. So constructive and credible look different in different places, and that's where culture comes in. There have been calls in the literature for medicine then to become a feedback culture, sort of as if it's no problem to just change your culture like you would change your jacket. But it's useful to think about what do feedback cultures do? Because I would argue that medicine is not really a feedback culture, but that sports and music really are feedback cultures. So what can we learn from them? What do they do that we don't do as consistently? Well, first of all, they embed direct observation in the way that they train people. I've asked a bunch of focus groups of music students how often they get feedback on a performance that their music teacher wasn't actually there to hear. And they don't know what I'm talking about. And they said, well, that's not possible, is it? I said, well, in medicine we give feedback to people a lot of the time on performances that we didn't actually see. So observation of work is really embedded. As I was driving here today, I was thinking about the fact that I think that imaging and training people in imaging is a particularly interesting place to study the notion of observation, though. I see pathology as potentially the same, having the same feature, which is that in a lot of ways you are training people in ways of thinking, and how do you observe that? So some of what we need to think about is how do we translate this general idea that in order to create credible feedback you have to have observed something to a task that is occurring largely in the head of the individual that you want to somehow make visible. So that's a bit of a challenge, but without efforts to be able to observe, to make visible the thinking, and that might be kind of talking through cases, walking a teacher through one's reasoning process, that sort of thing. Without that kind of effort, it's difficult to create credible feedback. The second thing that feedback cultures do is that they really embrace longitudinal teacher-learner relationships. Medicine, as a general rule, has not done that. There are all kinds of reasons that we haven't done that. I think there are some places in which we have valued breadth over depth, and so we want to expose people to as much different stuff as possible. And one of the downsides of doing that is that it robs people of the ability to develop longitudinal, trusting relationships with people who can sometimes tell them uncomfortable, difficult things and have them still find it meaningful and useful. So feedback cultures really embrace this idea of coaching, and coaching is a bit challenging in medicine, I think, because of the lack of those first two things. So these are just, I'll spend the last few minutes talking about these particular cultural challenges that I see in medical training that are making the idea of feedback a little bit more challenging than it might be in some other disciplines. One is limited observation, and the second is the idea that we kind of tend to mash assessment and feedback together. So let me talk a little bit about direct observation. Everything that you read about feedback would say that in order to create credible feedback, you have to have observed the thing. So we've known that for a long time, and we also have known for years that observation occurs less frequently in medical training than it should. Most medical students have been observed doing a history and physical, but many of them have not been observed more than once or twice. Residents in my discipline in neurology are very, very rarely observed taking a neurologic history, which to me is the core function of our work. So my colleagues and I were really interested in this notion of why don't we observe more often if we know it's so important? What are the barriers? And if you read the literature, there's some tantalizing information that suggests that learners and teachers are often pretty ambivalent about the whole idea of observation. Why would people be ambivalent about something that should be so educationally valuable? Sometimes my slides are too literal. This is to remind me to say, we wanted to study the hurdles to direct observation being more frequent. So here's a couple of things that we found. We found that first of all, we interviewed a bunch of residents and fellows about the experience of having been observed, and they all said that being observed was valuable. So that should actually reassure us. Being observed doing a procedure, or taking a history, or doing a physical examination, or even having their thought process made visible for observation in some way, learners thought that was valuable. But they also said that it came with a number of costs to them. It was emotionally uncomfortable. They often felt anxious about being observed. It could alter their performance. So they often felt like, what you just saw is not how I would normally do that. They said that when they were being observed doing something that involved direct patient care, that it often altered their relationship with the patient in ways that they found sometimes distressing. Especially when residents felt like in the hospital they were often the primary doctor for that patient, and they felt like the presence of an observer sometimes undermined the trust that they'd built with them. And then probably most important, residents always felt if they were being observed that they were being assessed. They put those things together, regardless of what the actual intention was. So there's a real need for clarity about what are we observing, why are we observing it, what do we intend to create as a result of this observation. This issue of clarity around am I being assessed or am I not being assessed is important. Sometimes neither the teacher nor the learner are quite sure what's actually going on. Is there a report that's going to come out of this that's going to go to the program director, or is this just for me to learn and to get better? If people aren't clear, then it's harder for them to kind of integrate and incorporate the feedback that they get. Because I'm so interested in culture and what the cultural influences are on these kinds of teaching and learning activities, we also looked at our data with this sort of socio-cultural lens in mind to say, what is some of the behavior around direct observation telling us about the culture in which it takes place? And we found that observation was probably a challenge in medicine because it seemed to consistently conflict with two important cultural values. One is autonomy and independence. Residents actually aimed to graduate from the need to have anyone observe them. And that's what we role model too, right? Most of us, once we're in practice, we never have anybody observe us doing our work. So there's a sense of graduating from the need to be observed. There's also a sense that sometimes you learn better by just being forced to muddle through in situations where you don't have the support of an observer. So that's one of the reasons for ambivalence about observation. It seems to come in conflict with that valuing of independence and autonomy. And then also teachers, learners, and our system and our government and the public value efficiency in the provision of healthcare. So it's not just that observation takes too much time, it's that observation actually seems to sometimes conflict with this real value of efficiency. And the last thing we found is that learners often had to initiate requests for observation. And they said, oh, our faculty are great, they'll come observe us anytime we ask them to. But they had to make the request. And if you have to make the request, and that request actually conflicts with these values that everybody holds in the profession, then the request becomes kind of fraught. Is a request to be observed a sign that I am needy, or that I'm willing to slow down a clinic or make people wait in the waiting room longer in order to get this observation done? It's a challenging thing. The last thing I'll mention is that we have a tendency in medicine to blur the lines between assessment and feedback. We often ask the same faculty member, the same teacher, to do both tasks with the same learner, often around the same task at the same time. And we do this for good reasons. You know, unlike a sports coach whose only accountability is to the athlete and to make them better, we as medical teachers have an accountability to the public and the community, that we not only help to make learners as good as they can be, but we also assure the community, the public, that they are safe to practice. So we kind of can't totally get around this idea that we have to both teach and assess, that we have to both coach and assess at the same time. But the problem is when it's happening at the same time in the same interaction and no one's quite sure what the interaction is about, then sometimes the conversation sort of falls flat. And learners have difficulty acting on something that they feel like is a judgment or an assessment, even if you intended it as developmental feedback. One of my mentors, Kees van der Vleuten, who's a medical education superstar, has said this great thing about programmatic assessment, which is really putting together a whole package of information about individual residents and medical students to understand how they're performing. He said, all actors should understand what they're doing, why they're doing it, and why they're doing it this particular way. And that really is just about this issue of needing clarity about what we're doing. If we are doing feedback and coaching for development, we need to be really clear about that. If an interaction is about assessment and judgment, are you ready to move to the next step? Is this individual ready to take call? Is this person ready to do their exams? Are you ready to actually graduate into independent practice? If it's about that, then people need to know it's about that. If it's about feedback and coaching and development, they need to know that. Often it's just blurry and unclear. So I hope that I've offered you some different perspectives on teaching and learning and on feedback in particular. One of the reasons that I like thinking about more than just the content of a feedback conversation, thinking about the players and the relationship and the culture and the context that it sits in, is because that actually starts to show us some of the reasons why some of these educational things might be so mired in inertia. Why is feedback barely any better now than it was 30 years ago? Why do people continue to say stuff like, I can't remember ever getting feedback that was useful? I think it could be because in our efforts to improve feedback, we focused entirely in one area. Basically, we bring teachers in and we do faculty development on how to construct good feedback. And we don't pay very much attention to relationship building, and we pay very little attention to the cultural either supports for or impediments to good feedback. And as long as we do those things and we keep taking trained teachers, motivated learners, and putting them into environments where good feedback is very unlikely to be able to be exchanged, then the cycle will continue to repeat. I wanted to just end by suggesting that there is hope for improvement and there's room for creativity. I'm just going to give you one example, and this is an internal medicine example, so not my discipline, not your discipline, but I think there's some lessons in this. Some colleagues of mine at UBC, who are a group of general internists, decided that they would try to address some of these issues and try to create more consistently meaningful feedback for their residents. And what they did was they recruited a volunteer team of internists who were willing to be coaches for residents. And the time commitment was not huge. They asked them to give up 3 or 4 hours of their time 3 or 4 times a year. And during those times, they would pair with one resident, the same one each time, and they just followed them around. The resident got to choose when they got followed around. Some chose to be followed around on call because that's a time when residents' work is really often unobserved. And their whole job during that time was just to watch, make some notes, and then sit and debrief and give feedback and really offer coaching. Importantly, they were not assigned patient care duties at the same time. So these faculty members were not also trying to take care of the patients. They were not the most responsible physician. They were just the coach for that 3 or 4 hours. And they really tried to ground this in these principles. Feedback has to be based on direct observation. It should occur in the context of a longitudinal relationship. That's what they tried to create. And you can see it wasn't an extended longitudinal relationship, just 3 or 4 times over a year. And they also said feedback was for the sole purpose of coaching. Nobody collected this. The resident might have got a written record of it just for their own information, but this didn't go to their program director, and these coaches didn't actually participate in assessment decisions about these particular residents. And what they found was that the residents thought that the quality and the extent to which it was meaningful of the feedback they got was much higher. And these residents, of course, had their normal feedback in the course of their normal clinical work to compare to. So they knew what they were used to getting, and they thought they got much more consistently useful information. And the coaches actually felt much better about their role as teachers because they really felt like they could construct something that was useful to their residents. So that's one example, and every discipline is different, the way you train is different, the things you care about are different, but it's a matter of thinking about how could principles be adapted to your own environment. And so I kind of leave you with this idea to think about. How do you make room for feedback as a conversation within your own teaching and learning environments? And I think that the CBME link here is just to remind you again that CBME is going to raise the stakes. We can't afford to have people in training longer than they are now. If we want to really help people move efficiently and effectively forward, we're going to have to get very expert at being able to coach them. And I hope I've given you some thoughts about how you might approach that. So thank you very much.